What if the very thing keeping you alive has been completely misunderstood? What if everything modern medicine has taught us about the heart only tells half the story? For centuries, the human heart remained an absolute mystery, an incomprehensible, shuddering mass, the driver of emotion, the seat of the soul. Surgeons refused to touch it. Religions forbade its manipulation. Philosophers debated whether it held the mysteries of love, courage, and the human spirit. The heart was the last organ to be operated on, not because surgeons lacked skill, but because of deep cultural and religious taboos spanning thousands of years. Then something remarkable happened. Doctors began taking extraordinary risks. They operated on beating organs. They connected patients to donors through tubes and machines. They invented devices that defied death itself. Some of these pioneers sacrificed their careers. Many sacrificed lives. But they transformed how we live. This is a story told in heart. A history by Dr. Sandeep Jauhar, a cardiologist who directs the heart failure program at Long Island Jewish Medical Center. His book weaves together centuries of medical breakthrough with one family's tragic encounter with the very organ that defines us all. This is not merely a medical history book. It is a meditation on what it means to truly understand the heart in our modern age. In this video, you will discover the revolutionary innovations that conquered the heart. You will encounter the audacious pioneers who risked everything. And you will learn something profound. Technology alone cannot heal our hearts. How we choose to live matters far more than any device we invent. The personal heart before the medical heart. The story begins with a young boy lying in bed, utterly fascinated by his own heartbeat. Little Sandeep Jauhar, obsessed with the mysterious organ pumping inside his chest. Why was he so captivated? Because his family carried a dark prophecy, a shadow that would shape his entire life. In 1953, on a sweltering summer day in India, his paternal grandfather experienced a moment that seemed to confirm something terrible. A black cobra appeared. In that moment of fright, his grandfather collapsed and died. A heart attack, perhaps triggered by the terror of seeing the snake. Some blamed the serpent itself. But his grandson, now a cardiologist, understands. His grandfather had succumbed to the most common cause of death throughout the world. This was not the biological heart a physician studies in medical school. This was the metaphorical heart. The heart where courage lives. The heart that races when we fall in love. The heart that breaks when we grieve. The very word courage derives from the Latin cor, which means heart. When Shakespeare wrote of romance, he placed it in the heart. When someone acts with bravery, we say they have heart. But here is what Jauhar discovered while writing this book. The metaphorical heart is not separate from the biological heart. They are inextricably linked. Emotions do not just feel like they affect the heart. They literally do. This is the central tension running through the entire book. In 1982, when Barney Clark received the world's first permanent artificial heart, his wife of 39 years asked the surgeons one question that captures this paradox perfectly. Will he still be able to love me? A question so profound, it reveals everything. We have technology to replace the mechanical heart. But can we replace the heart that feels? Broken heart syndrome. When metaphor becomes biology. One of Jauhar's most striking examples involves a patient who arrived at the hospital with all the signs of a massive heart attack. Chest pain, shortness of breath, distended neck veins, water filling her lungs. The medical team suspected a blocked coronary artery. They prepared for emergency intervention. But when they performed coronary angiography, something extraordinary emerged. Her coronary arteries were pristine. Not a hint of blockage anywhere. Yet her heart had weakened to less than half its normal function. The ultrasound revealed something remarkable. Her heart had deformed into an unusual shape. She had developed Takotsubo cardiomyopathy, broken heart syndrome. The condition gets its name from a traditional Japanese fishing pot that traps octopuses. It has a narrow neck and a wide base. That is exactly how her heart looked on the ultrasound. What had caused this transformation? Not a physical obstruction. A profound emotional event. Grief, loss, emotional trauma. The woman's emotional state had so severely destabilized her physiology that her heart literally changed shape. Her mind and her body merged into one broken organ. Jauhar informed her that the condition would likely improve once her emotional state returned to baseline. He was correct. As weeks passed and her grief subsided, they repeated the ultrasound. Her heart had returned to normal shape and function. There truly is such a thing as heartbreak. Emotions can disrupt the very mechanics of the organ we thought was purely mechanical. The boundary between metaphor and biology is far thinner than we acknowledge. The 1,000-year taboo that prevented surgery for most of human history. The heart remained absolutely off-limits to surgery. You could not cut into the seat of the soul and expect the patient to survive. The organ was too sacred, too vital, too mysterious. Surgeons could perform operations on the liver, the spleen, the intestines, but the heart remained untouchable. The taboo lasted millennia. Across cultures, across religions. This taboo began to shift only in the late 1800s when surgeons started performing emergency repairs on hearts injured by trauma, knife wounds, gunshot wounds. In these desperate cases, when death seemed certain without intervention, surgeons took the extraordinary risk of opening the chest. Then, in 1893, something unprecedented happened. In Gilded Age Chicago, Dr. Daniel Hale Williams made history. An African-American physician during a time of brutal segregation. Williams performed the world's first successful open-heart surgery. A patient arrived with a knife wound that had penetrated the pericardium, the protective sac surrounding the heart. Williams opened the chest, repaired the pericardium, and closed the wound. The patient survived, not only survived, but lived productively for decades afterward. The 1,000-year taboo had been shattered. The impossible had been accomplished. But Williams operated on a stationary heart. The moment the heart resumed beating after surgery, any sutured wounds would reopen. The patient would bleed to death. This fundamental reality meant that complex heart surgery remained impossible. You could not fix what you could not stop. You could not suture a moving target. The audacious solution that changed everything in the 1950s. Cardiac surgeons faced an intractable problem. Patients with complex heart defects needed surgery, but the surgery itself was impossible because the heart kept beating. You cannot suture something moving, cannot safely cut into a beating organ. Dr. C. Walton Lillihei envisioned something that sounded like pure science fiction. What if you temporarily took over the work of the heart and lungs? What if you connected one patient's circulatory system directly to a healthy donor's? The donor's heart would pump blood for both patients. The donor's lungs would oxygenate the blood for both. The patient's heart could then be stopped, opened, repaired. The concept was not only audacious, it was stunningly crude. Lillihei tested it on dogs first. He connected the circulatory systems of two animals using beer tubing. The donor dog's heart pumped blood for both. Incredibly, it worked. Terrifyingly, it worked. In 1954, Lillihei attempted this on a human for the first time. A woman with a serious heart defect lay on an operating table. Her circulation was connected to her sister via plastic tubing. The sister's healthy heart began pumping blood for both of them. Lillihei then operated on the patient's heart. She survived. The impossible had become possible. This cross-circulation procedure paved the way for the modern heart-lung machine. Later refinements created the sophisticated devices we have today. But the fundamental breakthrough came from Lillihei's willingness to imagine a solution that should not have worked. A desperate gamble that transformed cardiac surgery from a death sentence into a viable specialty. Thousands of children born with heart defects could now be saved. Thousands of adults with damaged hearts could be repaired. The device was crude. The technique was terrifying. But it worked. The accidental invention that saved millions, not all great innovations, emerge from brilliant planning. Sometimes they come from accident. Wilson Greatbatch was an electrical engineer working in the 1950s. He was trying to build a device that would record the electrical signals of the heart. One day, he reached for the wrong electronic component. A loud whistling sound emerged from his circuit. A simple mistake, but Greatbatch noticed something fascinating. The whistling sound had a rhythm, a regular pulse. It resembled a heartbeat. An idea struck him with force. What if this device could actually replace a failing heart's electrical rhythm? What if it could stimulate a fibrillating heart back to regular beating? Greatbatch pursued the vision with intensity. He miniaturized the device. He implanted it experimentally in animals. It worked. Then in humans, the pacemaker was born. An accidental invention that emerged from reaching for the wrong component and recognizing the possibility within that error. Today, millions of people alive owe their lives to a man who made a simple mistake and followed where curiosity led. The historical bias that shaped modern cardiology in 1948. Scientists began the Framingham Heart Study, one of the most influential medical research projects in history. They followed thousands of Americans over decades looking for the risk factors that predicted heart disease. The study yielded remarkable discoveries: cholesterol, blood pressure, smoking. These factors emerged as key predictors of heart attacks and strokes. But here is what Jauhar reveals. The Framingham investigators initially considered examining psychosocial determinants as well. They looked at whether emotional dysfunction, marital quality, psychological stress, and social isolation predicted heart disease. These factors seemed promising. But ultimately, the researchers decided to focus exclusively on what was more easily measured. Cholesterol could be quantified. Blood pressure could be recorded. Emotional stress was messy, unmeasurable, difficult to treat. The psychosocial factors were eliminated from the study. What emerged were the chemical and mechanical risk factors we treat today. And we have been extraordinarily successful at treating them. We lower cholesterol with statins. We control blood pressure with medications. We encourage people to quit smoking. As a result, mortality after a heart attack has dropped dramatically. Doctors have lowered the risk of dying from a heart attack in a hospital to approximately 3%. This is a genuine triumph of medical pharmacology and technology. But Jauhar argues this triumph came at a profound cost. We have become obsessed with treating measurable mechanical factors while ignoring the emotional and psychological factors that profoundly influence heart health. The American Heart Association did not recognize psychosocial stress as a key modifiable risk factor for heart disease until recently. Why? Because it is far easier to prescribe a pill to lower cholesterol than to address the emotional stress destroying someone's heart. Yet the evidence is undeniable. Studies show that people experiencing chronic stress are more prone to heart attacks. Lonely people have higher cardiovascular mortality. Unhappy marriages can bring both chronic and acute heart disease. The death of a beloved spouse often triggers a heart attack in the surviving spouse within a year. Grief, loneliness, loss, and emotional trauma leave marks not metaphorically on the heart, but biologically. The coronary vessels constrict. The electrical rhythms become unstable. The organ weakens. The metaphorical and biological merge. Shortness of breath, when the prophecy nearly fulfills. At age 45, despite exercising regularly and maintaining what seemed like a healthy lifestyle, Dr. Jauhar experienced shortness of breath while climbing the stairs to his office. What followed was a series of tests. And then the revelation: blockages in the coronary arteries. The very arteries feeding his own heart. Sitting alone in that dark room, staring at the images of his own heart, he experienced something profound. He was looking at his own probable cause of death, his family history. His grandfather's sudden collapse. His own arterial obstruction. The prophecy seemed to be fulfilling itself. But this brush with his own mortality transformed him. He began examining his own emotional life with rigor. He realized he had been caught up in the rat race, imposing inordinate stress upon himself. His career, his ambitions, his constant drive to achieve. He started practicing yoga. He meditated. He spent more time with his children. He began relating more authentically to his patients now because he had confronted his own fear of death. The pioneers who experimented on themselves. Throughout the book, Jauhar introduces us to cardiologists who were an unusual breed. They were not content to experiment only on others. They experimented on themselves. In 1929, Werner Forssmann, a German physician, performed a procedure that seems almost insane by modern standards. He put himself under local anesthesia. He inserted a catheter into a vein on his arm. Then, watching via X-ray, he threaded that catheter into his own beating heart. He was the first human to have a cardiac catheterization performed. He did it to himself. Why would a doctor risk his life like this? Because he believed in his idea so profoundly that he could not ask another person to bear a risk he would not bear himself. Forssmann survived. His self-experimentation proved the procedure worked. Decades later, others refined his technique. Today, cardiac catheterization is a routine procedure performed on thousands of patients annually. It paved the way for coronary angioplasty, for stent placement, for much of modern interventional cardiology. Later, Andreas Grunzig, a pioneer in balloon angioplasty, underwent a coronary angiogram on himself. He wanted to understand precisely what his patients experienced. He wanted to know the fear and discomfort firsthand. These self-experimenters risked careers. They risked lives. Because they believed the knowledge gained was worth the personal danger. Their willingness to suffer what they asked of others transformed the field. The paradigm shift medicine still refuses to make. Jauhar concludes his book with a profound argument about the future of cardiology. Medical technology has transformed the field. We have conquered many of the mechanical problems of the heart. We have lowered mortality after heart attacks to 3% in hospital settings. We have devices for almost every cardiac ailment, but we have hit a ceiling. Further progress will not come from better drugs or better devices. It will come from addressing the psychosocial factors that damage the heart. To treat hearts, we must address stress. We must examine loneliness. We must look at poverty and income inequality. We must understand marital quality. We must recognize that a loveless marriage can create heart disease as surely as high cholesterol. That financial insecurity can damage the coronary vessels as certainly as smoking. Yet Jauhar observed something troubling in his cardiology training. Not once did they discuss the effect of stress or emotions on the heart in any formal curriculum. Not in any major lecture. The focus remained entirely on mechanical and chemical interventions. Medications to lower cholesterol. Procedures to open blocked arteries. Devices to restore normal rhythm. What was absent was any systematic discussion of how to help patients manage emotional stress, how to address loneliness, how to strengthen relationships, how to create lives less dominated by financial worry and career anxiety. These things are harder to quantify than ejection fraction, harder to measure than cholesterol levels, but they matter profoundly. The invitation to live differently. Jauhar's central argument is revolutionary in the context of modern medicine. He is not arguing that drugs and devices are unimportant. They have been transformative. But he is arguing that future progress in cardiology will depend more on how we choose to live than on any medication we invent or any machine we build. The heart is both a mechanical pump and a vessel imbued with profound meaning. It responds to the quality of our relationships, to our experience of stress and peace, to our sense of purpose and connection. Medicine has mastered the mechanical aspects of the heart. What remains is to integrate the emotional, psychological, and spiritual dimensions of the heart back into how we practice cardiology and how we live our lives. The revolution still waiting to happen. The great irony of modern cardiology is this: we have conquered the untouchable organ. We have performed thousands of open-heart surgeries. We have invented artificial hearts. We have transplanted donor hearts from one person to another. We have devices for every rhythm disturbance. We have medications for every condition. Yet heart disease remains the leading cause of death globally. Why? Because the paradigm shift Jauhar points to has not yet occurred. Cardiology has not fully integrated the psychosocial dimensions of heart disease into its practice. We still treat the heart as if it is primarily a mechanical pump that can be repaired and restored through technology alone. But every time a patient develops Takotsubo cardiomyopathy from grief, every time someone suffers a heart attack following divorce or financial loss, every time loneliness predicts cardiovascular death better than any chemical measurement, the heart reminds us of something medicine would prefer to ignore. The biological heart and the metaphorical heart are one organ. They cannot be separated. They must be treated together. Jauhar's invitation is to recognize this truth. For doctors, for patients, for everyone, your heart will respond to how you live, to the quality of your relationships, to whether your emotional life is characterized by peace or turmoil, meaning or emptiness, connection or isolation. The devices and medications are important, but they are not enough. The revolution in cardiology has not yet occurred because it requires something harder than inventing new technology. It requires changing how we live. The beating heart over a lifetime. Consider this. The heart starts beating 3 weeks into fetal life, even before there is any blood to pump. It is the first major organ to develop in the human body, and it is the last major organ to stop working. A mechanism of remarkable reliability and endurance. The heart beats approximately 3 billion times over a lifetime. The amount of blood that passes through an average adult heart in a week could fill a backyard swimming pool. This muscular, constantly toiling organ is simultaneously so vulnerable to blockages, to electrical disturbances, to the emotions that flow through it.